Optimal health for high performers. This is the Health Upgrade Podcast with Dr. Nawaz Habib.
Hello, everybody. Welcome back to the Health Upgrade Podcast. This is Dr. Habib. I'm here with JP. How are you, sir?
Doing really well. Thank you.
Amazing. And we have our wonderful special guest today, Dr. Efrat Lemandre. How are you?
I'm great. I'm so excited to be here.
I'm excited to have you here because today's topic is a little different from us digging into the scientific side or into the clinical side of things, but rather we're going to talk about how we can be a better patient and a better practitioner, depending on which side of the table you're on, because the epidemic of medical gaslighting is pretty intense. It's not by any malicious intent by any specific side, but it has a whole lot to do with the fact that we're presenting ourselves in possibly a less than optimal way. And so I would love to dig into your story first and give you the opportunity to share who you are and how you became the medical disruptor that you are.
Thank you so much. First, shout out to your podcast. I love the name of it. Hello, Upgrade. I love it. Also, shout out to Dr. Habib because he was on my podcast 1,000 years ago. And I came to him for medical advice, myself and my wife. And so he was extremely impressive. Anyone listening, Dr. Habib is the man, and set up a session ASAP. So my story, I'm a nurse practitioner and I have one of the largest NP-owned practices in the country. And, I have like 20,000 patients, and I was schooled very much in the typical conventional medicine way. And this is true for anyone listening, NP, MD, PA, DO, we all go through, the content, the curriculum that we use is the same. We have different pathways to it, different lengths of time that we spend on it, but we all use the same Bible. Evidence-based medicine is the gold standard, and that's the Bible that we listen and preach and practice. And I practiced very successfully, and for many, many years, just kind of did the thing. And then one day, my wife got really sick. And easy, I'm a clinician. She's a clinician. All our friends are clinicians. Like, we got this, no problem. Well, we didn't have it. I'm going to make a very long story short. We hit a wall, a lot of shoulder shrugging. You're going to need medication for a really long time. By the way, she had PMLE, which is basically an allergy to the sun. So we lived like vampires. We just couldn't leave the house until after 4. And so we accommodated, right? All our listeners accommodated to their first blow. They're like, it's okay. I got through this. But then I started digging. You have to remember, dear listener, that there was a time before the internet. So some of the things I might say now will be like, duh, how did you not know this? Because like every influencer talks about it. But it wasn't like that, 2 decades ago. So I was sitting in this office in this shared space, and these chiropractors, I was telling them my wife's story, and they were like, oh, there's this thing called functional medicine. I'm like, oh, okay, what cringe nonsense is this going to be about? And they're like, you should see this guy. And I was like, honestly, though, I had nothing to lose. And there was a part of me that just kind of wanted to prove him wrong. Like, this is nonsense. I know every journal about PMLE. My wife and I were very, very well versed in the protocols. And so we went, and this crazy person did these crazy tests that we'd never heard of. And they had the audacity to suggest that my wife's autoimmune issues were related to her nutrition, which is crazy, right? Because first of all, we never learned that then 20 years ago. And we never learned it in the Bible, in the curriculum of evidence-based medicine. Like skin and belly, there's no connection. And that's why I'm saying it this way, because your listeners are savvy, and they're going to be like, how did you not think of it? And they're like, it did not exist 20 years ago. And the cool thing was that by that point, she had developed psoriasis. So like we could see it. So the cool thing was, there was no denying progress. It's not like fatigue, like, am I better? Am I worse? Or brain fog, like, I'm not really sure. Like, either your psoriasis goes away or it doesn't. Like, it was it wasn't black and white, it was red and white. So she had to, like, we took photos because we just couldn't believe, like, all these plaques going away. And, once you see, you can't unsee. And so then I started taking another class. Got certified in IFM. Then I got my PhD in integrative medicine. And I never practiced the same way again. I still practice clinically. I still have a primary care practice. For a while, I did functional medicine, but now I just speak on stages about medical gaslighting. I'm gonna promise I'm wrapping up because no one wants to hear this long biography. But the point about talking medical gaslighting from my perspective is I am a recovering medical gaslighter. Like, I did this for years, and I innately know where it comes from and why it happens.
That's actually a great area for us to go into, because having been in that position for as long as you were, and not necessarily, like, there was no negative intent. You didn't intend to necessarily hold things back or not share specific pieces of information, or you know, say that something was woo woo versus not. But what was the cause of this? Where do you think the underlying issue was on the practitioner side in terms of the psychology of the practitioner?
Yeah, and still to this day, and earlier, and I welcome JP to question us after I say this. JP was kind of expressing some of what many people express. I want to remind people that the doctors you see now who are in their 40s and 50s and 60s went into school when they were 20. My son is in med school. He's a 21-year-old starry-eyed, person. He just wants to help people. He has no idea what's about to happen. I can't even explain to him that he's going to learn a lot of things that he's going to have to unlearn. So no one is going into this with malice. I'm telling you, I see these kids, they're all interviewing. They're all like bright-eyed, bushy-tailed, ready to save the world. No one is saying at 21 years old, instead of taking the easy road and just like, I don't know, let me not disparage other careers. I'm going to spend the next 10 years of my life studying, minimum 10 years of my life studying. Uh, may or may not be able, I have to delay starting my family, delay start making money, getting myself into a minimum of $500,000 just so I can come out and be an asshole. Like, no one's going in that way. Okay. You're really going in thinking like, I'm going to save lives. Like, this is the best thing to learn. Like, I'm just going to be able to impact lives. And indeed you can, right? There is so much to learn. And by the way, this is why I only let practitioners, clinicians on my podcast. I don't let influencers on my podcast because there is something intensely, I guess, magical in going through that curriculum and learning it. And then there's something about unlearning parts of it, right? So you spend 10 years, you learn it, and there's a lot of things. And I'm really sorry. There's no influencer in the world that's going to understand a lot of things the way it's taught in the medical curriculum. And there are a lot of life-saving things in there. But it is just a curriculum. And the problem in the curriculum is that it's not just the curriculum, it's also another piece of indoctrination that happens where like you could study the Bible in like university and just be like, oh, well, here's the Quran and here's like this Bible and here's the Old Testament. And you can look at it, and survey it and treat it academically. But we don't do that, right? If we go to church, we take the Bible and we study it and then we say, our Bible is the correct Bible. And any other Bible, any alternative Bible is inferior, wrong, and dangerous. And that's the problem here. So we don't treat the curriculum as just, hey, this is the curriculum we're going to learn. There's other curriculums that you might want to learn, but this is what and in the curriculum is embedded an indoctrination that says, by the way, this is evidence-based medicine, evidence-based. We don't question the evidence. We call it the gold standard, which is so like classically religious. Gold standard. We might as well put like angel wings on it. And then we call everything else alternative. And anything that is not rigorously studied in this evidence-based medicine is dangerous. And so you walk out not just learning the curriculum, but you learn to distrust anything that's not in the curriculum. And that's the troubling part.
Yeah, for sure. And, you know, I got introduced earlier to you as the first thing was inventor, but then it was lawyer. And not what I really am. I'm an engineer and a scientist, but I did go to law school. And I will tell you that the same experience that you're telling me about your son being bright-eyed and bushy-tailed and going off to medical school with all these great feelings, when you go to law school for the first year, there's a lot of that too. A lot of people who think, I'm going there to preserve justice and to stand up for the little man and all that stuff. And it's kind of funny to watch as you get to the third year, watching those first years sort of go through it. And you realize there's a lot more cynicism in law school, so you get there faster. But I think the message that you were, I think, also talking about, I learned at home because I am a science person. My father was a physician. He went to school in the 1960s. And I just remember him marveling at the things that I was learning about once I decided to sort of learn about immunology and neurology and science of health. He said, back when I went to school, JP, we knew what white blood cells were, and we were pretty sure they had something to do with the immune system. I mean, and that's the sum total of what they knew.
But
So
you're all talking about 50 years ago, right?
yeah, no,
Yeah.
oh, no. At this point, it's coming up on 60, almost 70 years ago that he went to med school. So it's, I look at it and I say, sort of what Huberman said on Bill Maher. He said that the amount of knowledge that we have globally about our health is maybe 10% of all that could be known. And it's probably closer to 5. Okay, those are his words. I think he's being generous also. And then he said, and he relayed the story of a UCLA professor saying that if you looked at all of the knowledge that's being taught in medical school today, and that includes NPs and PAs and DOs and MDs and the rest, if you look at those textbooks, probably more than 50% of it isn't missing. It's wrong. It's literally wrong. And then
Okay.
you step back and you say, okay, if you're being taught to be religious about this, to be almost a zealot as a professional healthcare provider, to stick by your training and tell everybody that you know everything, then there's a couple of consequences. One, you never want to say that you don't know. You never want to shrug your shoulders, even to your colleagues. You're going to act like Western medicine knows it all, okay? Because God can't not know, okay? And then the second thing is anything that challenges, even if it's medical science being done today, anything that challenges what you're doing is it's experimental. It's early. It's not ready. I mean, I think there's a great book by Marty McCary called Blind Spots, in which he talks about a number of different things that are just wrong that have persisted in healthcare. I won't go into sort of the really controversial ones, but the one that sort of stuck in my head was appendicitis. You get appendicitis, is it the right thing to do surgery right away? Well, it used to be that 100% of patients who came in with appendicitis had their appendixes removed. But that's not the standard of care now, but it took decades to get the surgeons to stop cutting people open and taking their appendix out. Because for many of these patients, antibiotics are fine. And you can go about your day and go back, the next day you're out I think you described somebody the next day traveling, 500 miles to go to a wedding and dancing the night away. So,
Sure. Of course, it depends how early you catch the
yeah,
appendicitis. And also, there were no antibiotics for a certain amount of time. So it always depends. But what you're describing, though, is not only in medicine. Like, it's just we're constantly learning. And what we knew 10 years ago was not, so this idea that the idea that things evolve and that not just science, our understanding, our history, our understanding of what we found in archaeology, our understanding of space, our understanding of, for goodness sake, social justice. I mean, who we allow at the table, how we used to behave to certain groups of people, like it all evolves and changes. So I don't know that pointing to the fact that things evolve and what we didn't know it's just in the rest of the rhetoric that's just not something that's specific to medicine. I think the issue is the piece where we insist, what you said earlier, where we insist in when we come out of school that our way is the only way. That's a problem. And that's a problem, Lord knows, in every part of I'm sure you have some lawyers who are like,
oh,
you
sure.
could be disbarred if you do that. And some people are like, I don't even want to be on the bar. So there's just a lot of variations on the theme. But I think what's really important here, in this part of the conversation, because we're going to get to the patient part, but it's really important to understand this indoctrination, because once we understand the indoctrination, we should be a little bit less mad. It's the anger that's not helping us. You can't be angry at the priest in like middle of nowhere America for like hating on his various like that's all he knows, right? That's all he knows. You could be like, I don't really want to be a friend, or maybe I'll come to you for church, but I don't necessarily like I don't know. I don't know what you do with priests. I don't want you to do something else. So but that he has a place, right? And I'm sure that for his parishioners, he's helped some people, and maybe he's helped the poor in his neighborhood. But as far as life advice, maybe I don't go for him. So we have to just I don't know, get angry. I might call him ignorant. I might say, okay, he's good for what he does. Maybe he has a great organic vegetable garden in the back of his church, but he's not malicious. He's ignorant. And I think that's really important because we get very mad at doctors. I'm not talking about the jerks. There's 5% of jerks in every profession. So let's forget the jerks for a second. If you have somebody who fervently is like, I can't possibly order this test for you. It's so dangerous. I can't possibly give you this antifungal. It's so dangerous. Like they're truly thinking, God will smite them down for giving you this thing. So it changes, it reframes our brain a little bit.
There is a piece of it though, and I've had recent conversations with a cardiologist about this. There is a degree of skepticism that the good ones, the good physicians, still maintain. But there's also, it's sort of like in a church. I think that's a good analogy. You don't want to be the blasphemer. You don't want to be the one to stand up and say no, because it's not just the priest who's not going to like you. It's the rest of the parishioners who aren't going to like you. And, for example, we were having a conversation about statins and whether or not statin drugs really have the benefit that they're advertised. And of course,
Sure.
We talked about relative risk versus absolute risk, and the absolute risk being really tiny. The changes in absolute risk are really tiny. But it's the entire LDL cholesterol myth that was, initiated back in the 1950s, and it's perpetuated. But to go and tell a patient, as a cardiologist, to go to tell a patient, don't worry about your high cholesterol, don't worry about your LDL level, worry about your glycocalyx, worry about exercise, worry about your mitochondrial function, that's what'll protect you. That you can't do that. You have the protection of the American Heart Association, the American Medical Association, the protection of the American College of Cardiologists, if you follow their guidelines. If you follow the guidelines of treatment, which they claim are evidence-based, but most of those studies are run by pharmaceutical companies with agendas. And at the end of the day, they feel protected if they advocate for the thing that they have the backing of those societies. If they go rogue and they start saying, don't worry about your LDL and do something else, and they're like Dr. Wolfson or some of the other people out there, preaching, which I think is the truth, they're out on a limb.
JP, it's interesting. Like we're saying similar things, but you're adding a conspiratorial edge to it. And you're adding like, if you're a good doctor, you stay skeptical. If you're like, and you're adding adjectives to it. We're saying the same thing, but you're adding an emotional spin on it. And that's the thing that I'm trying to break here. So like, we're not disagreeing. Also of note, in both of your stories, one you quoted a UCLA professor and the other you quoted a cardiologist. So both of your stories took more gravitas because you pointed to the people who study the curriculum. Which is interesting because they do that. Other influencers of that. They'll say like, their data is terrible. Let me tell you what a professor from Harvard said. Oh, why was the professor from Harvard if the data is terrible? So like, it's interesting that when we want to add gravitas to our conversations, like, look, a cardiologist told me, like, then it's good. But if a cardiologist tells you a statin, then it's bad. And I really want to try to break that rhetoric. Everything has its place. And it is not helpful for you or anyone else to add the malicious conspiratorial spin to it. I am saying the same as you. I am saying they are indoctrinated. So I will use that doctor for the things that he or she are good at. And I will not waste my energy on thinking they're maliciously doing this. This person went for 15 years of cardiology school, right? They're thinking of a statin design.
That person
and no, you're talking about the person who went wrong. I agree with you, but the people who spent 15 years. They're in a practice. They're in the hospital. They have kids. They truly believe that everything is what it is. They're not maliciously, and they're not bad doctors because they're not skeptical. Like, they're just living a life. They have bills to pay. They have not everybody wants to spend like their weekends studying things. So they have evidence behind them to give them the statins. And then we have outliers, disruptors, the disruptors that come on my show, disruptors that you mentioned yesterday, who decide, listen, I spent thousands of dollars and thousands of hours going deep into this with no reimbursement. Not everyone can afford to do that. And it's not just skepticism. It's also like, what is your life like that you could be like, you know what, I don't have to worry about like paying my bills right now. I could just spend my weekends in certification courses, take an extra class. Like, there's a lot of privilege in learning more here. So I'm with you, but I think it would behoove us to start. It's like getting a plumber to fix something in your electric, and then being like, the fact that he doesn't want to fix my electrics because he's not skeptical and he won't learn on the weekends. He's just a plumber. You're just a primary care provider. Like, we're the ones who give
I'm
them
going to push
more
back
work.
on that just slightly. I think we're in agreement, but this is a
I love
friendly,
the pushback.
friendly debate.
No, do it.
When the doctor takes on the role of being the position of being the God in the room who knows everything, because they're adhering to the Western medicine teachings, which is the analogy you used, and I agree with, then it does behoove that person, independent of whether or not they've got bills to pay, independent of whether or not they've got interest in it. If they're going to hold themselves out to be the Oracle of Delphi here, then it behooves them to learn everything there is to know to the best of their ability on the subject. And so I'll give you the example again with the cardiologist. Talking to a triple board certified cardiologist and saying, what do you think about the glycocalyx as the first failure mode, and that LDL cannot get through the blood wall, the wall of the blood vessel, if the glycocalyx is broken down. And that individual, the cardiologist, who was trained within the last 20 years, doesn't know anything about it. Has never heard of it. And
Okay.
because
So
because the
you
medical
don't know something that I
education,
know. Why don't you know
and I'm
everything
not
I
holding
know?
myself out to be God.
But no. The patients make them God. The parishioners that walk into the church make them God. You can only be a God if there's people in the congregants, because that priest in Alabama is not my God. I know I may buy vegetables from him, but he's not my God. Okay, the role of God, someone has to be
You're right here. The
worshiping.
onus falls
Dr.
on
Wahid, it sounds
the patient. The onus falls on the person who
So I'm a lawyer.
goes
I'm
up
a lawyer.
there. Yes,
I'm
I
a lawyer
see.
here, and I'm now going to put that hat on just briefly and say, I think that the physician is supposed to be the patient's advocate, not only for health. Okay, not for
advocate, but that's
that
a
means
different thing. If that doesn't mean that you can
no,
tell the physician they have to
no,
learn
but they
every science, every influencer's thing that they discovered about mitochondria, that's
but
what every
they
physician
should.
needs to do is learn. It's like it's a
It
crazy
maybe,
request.
but then don't hold yourself out to be right all the time, and don't rely. There needs to be a change, and I think the question is, who is going to be the advocate? Because I think that the patient needs to be an advocate also. Patient needs
Oh,
to be
100%. The onus, sadly, patients, when they walk into an office, give in, right? And they give up that responsibility. And they say, the doctor told me to do this. These are the doctor's orders. Literally, we've been gaslit by a system that has put us into the patient doesn't know, the doctor does. And this is the system and we have these preconceived notions. And so what I think, Dr. E, where you're trying to go here is now we can no longer continue to hold the doctor to that high standard of knowing everything, because ultimately they're human as well. They're never going to be able to know everything. They're never going to be in a position where they're fully aware of every single thing, and we can't hold them to that standard anymore. And so now we, as the patient, need to go into the office and say, you know what? I want to know what you know about this because I'm interested in this. And if we are aligned on this, if we're aligned on this topic, if we see things in a similar fashion, if you're willing to integrate some of the other care practices that I'm talking about, that I'm interested in, then we can create this doctor-patient relationship. But doctor comes from the word teacher, which I think is where JP's point is coming from, is if you're taking on the role of a doctor, then you're also, in theory, held to the highest standard of being able to be at the helm of that knowledge, at the forefront of the new knowledge in science. I think both sides need to be the advocate for both sides of this scenario. But for such a long time, for the last 30, 40, 50 years, patients have been gaslit into saying that the doctor is in this god or priest position where they are the provider of knowledge, and this is where the knowledge comes from. Things have shifted.
Let me say two things about that. First, gaslighting takes two people. You could try to gaslight me all day. I'll just close the screen. It won't work, right? So I have to stay for you to gaslight me. So when one of the things I talk about medical gaslighting, because it exists, is the fact that you, the patient, also participate in it. I'm not talking about the jerks, the people who are just like, oh, you go lose some weight. I'm not talking about the jerks. But you have to participate. You have to be like, oh my God, this guy didn't listen to me, as opposed to saying, and we'll talk about it more, as opposed to saying, okay, well, this person reached their end of their toolbox. It was really great to use those toolbox. I need those toolbox. I'm glad I got my scans. I got my CBC and whatever things that this PCP could order me. Great. And when he says, when I start talking about microbiome, and he's like, that's nonsense, I'm not going to take that as gaslit. I'm going to say that, great, I just discovered the end of your knowledge, which is amazing. Now, end of knowledge is really important because even in something like specific as oncology, it is literally impossible for an oncologist at this point in time to be on top of every clinical trial that exists in the world because they are moving so quickly. It's not reasonable to expect an oncologist to. So if you're someone who suffers from cancer and your local oncologist doesn't know it, he's not gaslighting you. It's your responsibility to go and find wherever the clinical trial is. But it's really impossible, especially in the amount of information that's coming out right now, for any clinician to be at the level. And even if you're going to go to Huberman, you're going to go to this functional medicine, your functional medicine person doesn't know everything. They know the one thing they're really good at. They might be great at Lyme. They might be great at mold, but they're not great at oncology. They're not great at interventional cardiology. Like everybody, if you want to talk about a lawyer, everybody should stay in their lane. If I know medical curriculum, then I should know medical curriculum. I don't need to know the latest scientific information on mitochondria, because if I do end up going into a lawsuit, my lawyer will be very happy if I stay in primary care. So everybody should stay in their lane. And the important thing is for patients to stop expecting their respective doctors to know everything in everyone's lane. What I would want to see, that I think a reasonable request of clinicians, is if they would, again, I said the curriculum is a curriculum and indoctrination is indoctrination. If they could take the indoctrination piece out and say, this is what I know to be true for your stomach. I cannot find anything else. I'm about to diagnose you with IBS. I don't know anything, but I've heard great things about Dr. Habib, and start adding alternative, in quotes, non-conventional people to your referral list. I think that is a more reasonable request than to ask your
Fair
PCP
enough.
to know everything that's out
Completely agree with that. I think,
yeah.
but what you're asking for is for the indoctrination at the medical school level and at the training, their postgraduate training, residency and fellowships, etc., to admit to them you don't know everything. You need to go and you need to know where your limits are, and then refer to somebody else who does. And within certain specialties, that's allowed. But it's not the way the medical education is structured. It's not the way the legal tort system is structured. It's not the way the insurance system is structured. It's not the way patients are. It's really unreasonable. The same way it's unreasonable to expect that the doctor's going to know every clinical study that's out there, which you're right. It's not possible to expect that most
Yeah.
patients are going to be able to go on, clinicalstudies.gov and find the right study for their genetic, breed of pancreatic cancer. That's not reasonable either. Now, there is the new technology of AI, which does have the ability to scan through it all, absorb all of that information, and come to the table and have a list of, say, these are the top 5 studies that you could qualify for and that you might see benefit from. Yes, there's new technology like that, but you show up at a doctor's office with a stack of papers, printed off, you're, the doctor's not
You're
going to be
out.
happy about that.
You're out.
So where's it
You're right.
break?
It breaks in what patients need to do. They also don't need to learn everything. They need to understand they need a healthcare team. Just like you wouldn't plan a wedding and have your DJ do your wedding cake, have your plumber do your electric. You can't have your PCP handle your microbiome. And you can't have your vagus nerve doc handling your HRT. I don't know if you do HRT, so I
Hormone
don't know if
replacement
that's
therapy? Yeah.
right. So no, I don't know if Dr. Habib does that, right? So I'm going to him for vagus nerve stuff. I don't necessarily want to talk to him about my estrogen and testosterone levels, right? So I need to understand as a patient that this notion that the doctor is a god is from the 50s. And I need to understand it. And I also need to understand as a patient that each person has they're humans. There's a certain set of what they're going to know. I will choose those that are like, maybe I like their personality. I feel like I can't even evaluate their knowledge base, right? As a lay person. I like their office. I like what they can do for me. And I will use them to the end of their skills. And then I will add teams. Just like I have a gynecologist. My gynecologist doesn't do my mammogram. I have to go to a special place for mammogram. Then I go somewhere else for a colonoscopy. I need a vagus nerve doc. I need someone else to do my HRT. I just got a different guide for my peptides. And I have to build a team. And our patients, you're right that they don't have to learn everything, but they have to start accepting that they cannot have it's not a one-person show. They need a team. They need at least, you need like 10 people. And unfortunately, and you are right, insurance will not cover it. But this way you also don't extend people past their scope. If you're forcing your PCP with your 10-page thing, they're not going to read it, but they're also uncomfortable because they're not going to be protected. Keep everybody in their lane. I am quite sure that even though Dr. Habib is really cutting edge, if I really asked him to manage my
100%.
hormones, he would feel uncomfortable. Yeah. So, and that doesn't, and he's not conventional, he's not indoctrinated. I just think so patients need to understand that each person in their lane. And, for patients, I see the pendulum swinging the other way. They're like, they had such a bad experience with their PCP. They believe they were gaslit so intensely. They find this one functional medicine provider that, of course they spend 90 minutes with you. You just pay $10,000 for it. You spend 90 minutes with you, so now you're mad at the person with 15 minutes with you because they only got paid $100 for it. And then you start going to the other side of the spectrum. You're like, don't do the mammograms. You don't do anything. I know mammograms are controversial. Let me just check something else. Pap smears. You won't do anything at all. You won't even get evaluated to see if you have, God forbid, a cancer. You won't get the colonoscopy. Then you won't go anything. And so that spectrum is also indoctrinated. I won't do anything in primary care. So we should just be discerning patients, get a team, and lower our expectations.
The problem is that what you're suggesting, and don't get me wrong, for somebody like me, sure, what you say is absolutely right. But I'm just going to point to the 95% of the population that doesn't have the knowledge and doesn't have the financial resources and doesn't have really access to the team of people to be their advocates. Now, maybe, again, I'm going to point again to AI. Maybe AI can do that. I mean, I haven't used it that way, but I can imagine being, somewhat conversant in AI, I think pretty
And
well.
they're all starting to have like a health-based component that you can utilize for your own or whatever. I get that there may be privacy issues and whatnot on the AI side, but they are starting to incorporate health-specific tools for everyone.
Yeah, and I think that can be a good start for the 95% who don't have the $10,000 to spend on a concierge practice that's going to align you with all of the different, because I mean that's what some of these concierge practices do. They're not they're not actually treating you beyond the scope of what they know, and it's narrow, but they then serve as the connector for you to everybody else.
There's nothing that we're discussing on this podcast or any podcast that is accessible to 95% of the population. 95% of the population thinks McDonald's is food and eats Dunkin' Donuts every single morning. So they're also not the listeners of these type of podcasts. And luckily there still is a system that's going to try to keep them from having a heart attack, because I have plenty of patients not only don't have knowledge, also don't have a desire. And they need the 3 medications for their diabetes and their GLP-1s and their statins, because they're still eating McDonald's every day. And my goal is to try to keep them from having a heart attack when they're 40. So it doesn't make my logic wrong, incorrect, I should say, that 95% of the people can't access it. That's the reality. That now we're talking about having to change the entire, not just trajectory of medicine. We have to change everything about social determinants of health, where people live, how educated they get, who has access to education, who has safe neighborhoods, who doesn't live in lead paint, right? So now it's not even a conversation about indoctrination or medical gaslighting. We're talking about what we prioritize as a society, not allowing McDonald's food. I mean, when you leave this country, what's on, at least in some countries I visited, on the corner are places that sell nuts and dried fruit, not munchkins. So you are right. 95% of people won't be able to build a team, but
Well,
that is a much
maybe
bigger issue.
I was scoping this conversation a little differently from the way you were. I guess what you're saying is, to the listening audience for this podcast who are interested in health, who are biohackers or professionals, healthcare professionals, get a team, be an advocate. Don't be so doctrinal about your positions on things. Recognize your limitations. Recognize the limitations of the provider you're talking to. All of those things are great teachings and great advice for people who are in that rarefied air. I guess from my perspective, I was looking more at the whole system and saying, how do we ensure
The whole system's fucked.
You've broken new ground. You've broken new ground on this
I got
podcast and
nothing
dropped
for
the
you.
F-bomb, which no, it's all good. It's all good.
We're
Shit,
happy
I'm
you
sorry.
did. Someone had to.
It's, but the point I'm making is that if you're going to address it for everybody else, then you're right, the system is screwed up. And what we need to do is introduce a different, just sort of wipe the slate clean of the mindset. And I think that's already happening. I think I'm going with the flow. I think that there is a larger and larger and larger group of people who distrust doctors, who distrust the pharmaceutical companies, distrust insurance companies. They're out there praising some guy who murdered the CEO of an insurance company. I mean, he has fanboys. Okay, that's not a good thing. That is a beacon. That is a blinking neon sign to the system that they need to change their perspective. They need to change things, because when somebody gets murdered and people are cheering for it, that's showing that the 95% that we're not talking about today, that we should be, that 95% is pissed off and they're not going to take it.
JP, of course the system is messed up, but I have to say that spreading conspiratorial, angry information from the 5% that is largely happening is not helpful. It is not helpful to come up with, I distrust my doctor. That's because you put too much trust in him to begin with, not you. In general, you're talking about distrusting. So people, what if the rhetoric looked like, if all the Hubermans in the world stopped saying, oh, this doctor, don't trust it and don't go here. What if we were like really just openly transparent? Like, when you go to your PCP, you're only going to get this curriculum. But by the way, sometimes you really do need it. I mean, if you have gonorrhea, for goodness sakes, you want to go to your PCP, okay? No sage in the world is going to help you, right? So we need the medical curriculum. We have to stop saying we distrust it, because all the people listening to this podcast still go to the PCP and they still go to the urgent care when they're not, and they still go to the emergency room. So we need it. We have to reframe it of, instead of distrusting it, trusting for doing that thing only. And pharmaceutical companies, we know they're profit driven. So we know that their research is going to be about
So,
treatments.
so how do we
and we use it for
redefine
that.
Because for such a long time,
Right
yes,
here,
right
right now in this
the whole
conversation.
The
I
problem
love
is
it.
the problem is you've got if you've had interactions with another human being, and 99 out of 100 times they were honest and truthful with you, but one time they weren't. One time they told you something that was not true, and you knew it wasn't true.
They didn't lie. It was
See,
their truth.
I come from a framework that says that the truth is something that is an absolute, and then
You just said your cell science keeps changing. Your dad thought white blood cells was one thing. Is that lying?
Okay, so if I go to a doctor and the doctor says, "Hey, JP, your cholesterol's high. Stop eating eggs." Okay. But that doesn't mean it
That's
is
their
the truth,
truth.
and it's not the scientific truth that's out there. Saturated fat that you eat in your diet and cholesterol that you eat in your diet has nothing to do.
That's the scientific proof that you use, but they are going to point to scientific truth that they use. They're not making this up. They have mountains of evidence, as you have mountains of evidence for things. But they're not lying to you. They're not saying, I know there's other truths out there, but I'm going to insist you don't eat eggs. Please believe me. They truly and fervently believe that eating eggs is a problem. So they are truly telling you their truth. They're not lying to you.
I'm not suggesting maliciousness, but I am suggesting that the patient be distrustful. Because if the patient is distrustful,
or skeptical, maybe not distrustful, but skeptical at least, maybe.
No, utilitarian, not skeptical, not distrustful. Utilitarian,
but skeptical
use
with the idea
the way you use
of
an
it being
electrician.
utilitarian in function, right? Like,
yeah, but without
100%.
the emotion of distrust,
but objectively,
or the emotion of lied to 99%
skeptical,
of the
not
time.
subjectively, not
Like,
this is my truth or whatever, but objectively skeptical, I think is allowed. Yes. Because, or that for me is objectively the goal, right? Because when a patient brings something new to me, okay, and it's something I've never heard of, my first instinct is not to say no to it. And I think that's where I am different from other practitioners. And I think this is where what the doctor should ideally be doing is taking their ego out of the way and saying, hey, I honestly don't know about this. And when the doctor says, I don't know, you're creating a bond of trust because what you're saying is, I don't truly know everything. And I think that is what, for a long time, doctors did, is they did not say, I don't know. They just said no.
And they still,
that's where the problem was. And it's changing, thankfully. And we see that with AI being this wonderful force in some capacity for allowing us to get more new information into our realm.
You had that
the pop happened again.
I think they'll just cut it out.
For me, where for where I want to go with this is, I think, Dr. E, you're right here. The onus is on both sides. The onus is, number one, on the patient to be to look at that relationship as purely utilitarian. What do I want out of this scenario? So if I'm in a situation where I need urgent care, I'm going in for urgent care. I'm not going to talk to them about my microbiome in this specific instance. And that's probably the right way to go. And the doctor doesn't want to talk to you about their microbiome or your microbiome when you're having a gut distress issue or whatever, broken arm, right? So great. Now we've got that utilitarian situation. But now when we talk about a PCP, and 95% of people have one practitioner that they can rely on. Well,
I love these
this is the 95
that we'll
95,
go to. 50%, 100. It's always like these perfect numbers. Go ahead. By the way, any listener should be skeptical when these 50% of 99%.
The vast majority of Americans, Canadians have one practitioner that they rely on, one person that they go to. What we start to need is having that practitioner not want to be right about everything and be okay with not knowing on the practitioner side.
Dr. Habib, the problem, love you so much. I love that you think that ego and the inability to say, I don't know, is just with doctors. For any woman listening, girl, every man in this planet can say, I don't know. But, so like, and this is important, and this is really important, and I'll tell you why.
So for me,
I'll tell you why. I know, but it's medical gaslighting. No, but I'll tell you why it's important. And I liken this to that. It's medical gaslighting because you cannot ask others to change. So you ask me what would be the ideal ask. Sure, I want all doctors not to have ego. I want all men to stop thinking with their other side instead of their heads. I want a lot of things in life, but that's not going to happen.
So
full stop.
Half of our listeners are practitioners, and that's why I'm saying it in that, or that's who I was speaking to on that particular topic. Yeah.
If you're a clinician listening to this podcast, you're already
ideally
removing the
yes,
brainwashed.
yes.
So you're already halfway there. Ideally, and the only thing, so let me speak to those clinicians. The only thing you have to say, you don't need another certification. You just need to say, I don't know, to Dr. Habib's point. You just need to say, I don't know. And next step would be wonderful if your referral list included, here's an acupuncturist, here's a microbiome specialist, here's a vagus nerve specialist. Do you, but here's the people I've vetted over time. That's what I do in my podcast. My podcast is like, we don't sell anything. We have no courses, no webinars, no nothing. It's literally, we want you to go to the website and say thyroid, and we will have found vetted clinicians, not an influencer with like a ring light, vetted clinicians who have also learned and then unlearned, and then you can go and decide what you want to do with it. I don't make anything from the transaction. That's what we want from the clinicians. What we want from the patients listening is to stop being angry. Like, JP's anger is not healthy. Huberman's anger, I mean, it's great for likes and it's great to become like popular and these doctors, what the doctors won't tell you. 5 things your doctors won't tell you. It's just a load of garbage just to get you agitated, right? Agitation is not good for you. You're on a health journey. Find peace. The way to find peace is to understand everyone's limitations and work around them. So if you know your PCP has learned to be a god, you don't have to revere them. I can walk into any church and give the proper respect, but I don't believe in that religion. But it was a nice sermon. I could have heard maybe like I said, maybe they have a nice garden. Maybe they help the poor. I've donated. If you donated to the Red Cross, you've donated to something religious. Are you necessarily Catholic or Christian? No. Like there's so many other things in it. So get your own peace. Stop thinking that everyone's gaslighting you, again, except for the 5% of the jerks, and understand the limitations. And yeah, if you have one PCP, amazing. Use the PCP to the extent that you can. Get every test order that they're comfortable with. Get every blood work that they're comfortable with. And then if you can afford it, at JP's point, you get other people. If you can't afford it, that's the reality of a lot of things. And like now we're talking about, can we change the whole country? But in I'm going to say the 5%, since we said 95%, the 5% left that are listening here, the people who are listening to podcasts, health podcasts, primarily have more resources, whether it's financial or literacy, than the general population. And these podcasts are talking to them. I mean, that's the reality. And so for those people listening, I just want them to be a little bit less angry and just use the system for what it's worth. Because if you need a hospital, you need it. You don't want the hospitals to topple. Yes, they suck. Yes, we could do it better, but that's not going to happen tomorrow while you're on your microbiome journey. So, like, just find peace, man.
Listen, I think that's a wonderful sentiment, and I think that that's something that's a goal. It's a bit idealistic, I think, but I'm willing to get on board that bus and go there. I'm a little more cynical. Maybe it's because of that legal training that I said at the beginning that I didn't want to be associated with.
No, it's also your algorithm. Your algorithm has made you very cynical and angry.
But the algorithms are based on that. And I get it. But ultimately, the goal is find peace, right?
You mean the legal algorithm, or you mean like?
No, your algorithm of like your
really
socials.
Other
what
than
I'm
the
hearing you
podcast, I'm
saying,
not really on socials. My
you quoted Huberman.
Okay, I mean because I've listened. Okay.
So you're on some
But
sort of
Huberman
algorithm.
doesn't come out with anger. Huberman doesn't come out with anger, though. Like, I think what JP is trying to do is educate himself, and I think that's more than fair, right? And ultimately, as a discerning patient, when you can be in the position of a discerning patient, the goal is to educate yourself, right? Both as a patient and as a practitioner. Educating yourself, learning more, hearing opinions, that's great. Yes, the algorithm is skewed and their clickbait is a real thing and they drive you on negative emotions, and that's generally what you're going to click on in the world of being online and how the social networks work. On the patient side, finding peace. And I think where the issue lies here on the utilitarian component only is that as a patient want to hold our doctors to a higher standard, and in theory the system enables that to occur, but we can't hold them to the highest standard, and I don't think it's fair to do that. But we want to be able to have a conversation now. As a patient, I want to be able to go into my PCP's office and say, hey, this is what I've been researching. Do you know anything about this? Are you interested? And I think we as patients walking into that office should go in hoping that the doctor is willing to at least have that conversation. And where they don't know, say that they don't know. And as the patient, we should then be able to make the decision of whether we continue that conversation or continue that relationship in its ongoing sense. If we want to get better, if we're working towards optimization, a PCP isn't the optimization focused practitioner. So make a decision about potentially working with somebody else or taking a course or learning something different for yourself. But the onus, you're right, lands on the individual. One of my mentors, really great friend, Sachin Patel, said, the doctor of the future is the patient themselves, right? Their role is now to educate themselves. And so for me, as the practitioner, I'm going to say, because my goal for my patients is optimization, where I don't know, but I'm willing to learn with you. I'm willing to have the conversation with you. And I should expect that from the practitioners that I'm going to choose to work with, if I have a choice of practitioner. So resources aside, what should we expect of our practitioners?
Yeah. First of all, how's it feel to be King Solomon between me and
Hey, I
JP?
love this
Like,
kind of
you're
conversation.
like in the middle.
This is
of,
the
like,
best.
I'm into it.
cut the baby in half. Yeah, it's the best. Okay. So, and JP, thanks for being a good sport about it. About it all. Okay. First of all, stop expecting. Like you keep referencing yourself as if you are the
I
reference.
definitely do
I
not
will give.
want
No,
to
I'll tell
be, and
you.
I
I'll
don't.
tell you what. No, I don't mean it in a bad way, but I want you to see that you're like, well, when people come into me, I don't say that they're wrong, but you have already been unbrainwashed. You are not the reference point. You're already on this side. So
But that's
we
the
can't
expectation
expect
I
that
have
of
of
the
myself.
PCP. Of yourself, yes, but you said, and one of the things you said is, and I expect.
I said
You
I would
want to
hope. I
expect
said
or
I would hope. So
expect that from other
I don't
clinicians.
expect
Yeah.
my
So
doctor that I go to have
we
that
have to, like,
conversation.
so first thing I want you to do is get rid of that hope. That's first of all. I want you to get rid of that hope. So here's what I want patients to do. You asked me the question. Here's the question. I want patients to understand that they already have the skills to navigate healthcare, and they use it everywhere else except for medicine because they have been indoctrinated to believe that they have to be a good patient. There's some reverence. And I can't tell you how many times a day I hear in my practice, I'm so sorry to bother you. I know you're really busy. Like there's already this self-erasure. Like I'm just a really easy patient, right? I'm in and out. I was so fast. And I'm like, whoa, don't do that. Take your time, right? So the patients have also been indoctrinated to accept the system. I don't want to be difficult. I'm not like that guy. Like, right? So they're coming in loaded, and we're loaded from pediatrics, right? Pediatrics, if you don't cry, you get a sticker. You're so brave, and then it just continues on, right? Like it's a good patient from pediatrics on. Our parents come into the room, they lose authority to the doctor. That's because there's a lot of happening that by the time you're in your 40s and go to the doctor, you are a good patient, you are a good soldier. And some of you listening are CEOs, you're lawyers. You're like, you can go into a boardroom and you can like, let's go. But then you go into the exam room and you lose it all. So my goal is for you to really use the skills you already have. First, understand their indoctrination. They are nothing but a plumber or an electrician. Start seeing them as such and stop asking them to be other. That's first of all. Second, recognize your role. What are you doing as a patient? I'm not saying be disruptive or rude because we wouldn't do that, but stop self-apologizing. I'm so sorry I'm taking time. Girl, you waited in here for like a half hour for this. You filled out 46 forms. I'm not apologizing for my time. I'm here. Here are my questions. Second, third, I can't count. Third, believe in your bodily experience over any data. We have, as patients, accepted the fact that if we are presented with data and that is in contradiction to what we experience in our body, we assume the data is correct, right? So if I feel fatigued, my grandma and my aunt have hypothyroid, every woman in my family is hypothyroid, I'm feeling all these things, I'm gaining 10 pounds, things that I'm going to the gym every day, nothing's happening. My TSH comes back normal. I'm like, oh, it's got to be me. I don't question the patient generally doesn't question like, well, I must be in my head. It must be crazy. We are quick to make our bodily experience secondary to the labs. We would not do that anywhere else. If I walked in somewhere, I'd be like, I don't know, this doesn't feel right. And they're like, no, everything's fine. I don't know. Something in this office doesn't feel right. And everybody's like, no, what are you talking about? You would take that gut feeling and be like, I'm out of here. I don't know what it is. I can't pinpoint it, but I'm out of here. I'm not doing this deal. I'm not shaking this man's hand, whatever it is. But when in the exam room, we let go of that. If you are unsure about your bodily experience, pattern recognition is really important. Pattern recognition is what we praise in firefighters, in pilots, in radiologists. It's pattern recognition over and over again. But if a woman, I'm sorry, it's usually women and marginalized humans are saying, it's just not, it's not how it used to be. That pattern recognition is a strength that is praised everywhere else except for medicine. My kid's not behaving the same way. Every morning we're the same. Now he's not. I can't pinpoint it, but we immediately put our voice down. The doctor's like, no, he's fine. All his labs are fine. Then you'll go home and be like, I guess my pattern recognition doesn't count. Pattern recognition counts. So you have these skills. You use them everywhere. Stop handing them over when you're in the exam room. Now, that doesn't mean your PCP can handle it. It means that when your PCP says everything is normal, you're going to stand firm and say, I did my pattern recognition, whether it's some tracking or whatever. I believe my bodily experience. I know how to make a case. Because in my book, I also teach like how to say it in like doctor speak. This person is not answering me. Is he gaslighting me for the sake of gaslighting me? Probably not. Or has he reached the limits of his knowledge? Probably yes. Time for me to build a team.
I could not agree with what you just said more. I wish we had started this conversation on that foot, because I literally, I'm sitting here going, yes, you have to be your own advocate. You have to believe yourself. You cannot walk into the doctor's office and be told that what you're experiencing isn't true, because, you know, I've experienced that. God, I remember sitting in a room full of neurologists on two different occasions. One, it was a room full of neurologists who were epileptologists. Okay, they were studying epilepsy and they were treating epilepsy. They said that all the headache patients were crazy. And then I sat with a group of neurologists who were about headache, and they said, "Oh yeah, those epilepsy patients are nuts." You know, and I'm thinking to myself, "Hey, wait a minute. Maybe you're the ones who are nuts." And I realized that you're going to say, "Well, that's not really fair to say it about the doctors." But I sat there and listened to them both tell the other, blaspheme the other group. And I remember my dad as an OBGYN, because I actually think he was a lot like, Dr. Habib. He was way ahead of his time, because he said, "Listen, I've had these patients for 30 or 40 years. Okay, I've known them since they were, since their mothers brought them here for their first, gynecological appointment in their teens. I've known them that long. And so if they come to me in their 40s and they say something's different, I may not know what it is. Like, I know that they get fibromyalgia, they get IBS, they get these medical conditions that I can't figure out how to fix. And I don't think they're crazy. All my colleagues say, oh, these women, they're just crazy. Well, no, they're not. They're experiencing something. I don't think they're medicalized and they just like to go see the doctor. That's not fair. So I think that being an advocate for yourself is really important, but also being a good doctor is important. And being a good doctor is knowing, and I think Dr. Habib's right, know when to say, hey, I don't have this answer. Medical science hasn't gotten the answer yet, or at least they haven't taught me it, and I don't know it yet. And I think that's really important. And I realize that that's part of the system, but I think
I agree with
Right.
you that that's what I want clinicians to do, but they're not doing it anytime
You think the
soon.
patients are gonna do this,
So we
what you're
have a
telling them to
choice.
do sooner?
A patient is more likely to listen to this podcast or read my book and say, "You know what? I do this everywhere else. I'm a badass CEO. I'm badass at PTA. Everybody listens to me. Like wherever you are." But that's what happens in the exam room. Like more likely, someone's gonna listen to this podcast and be like, "Oh yeah, but girl, I had somebody who like was in front of the Supreme Court and she couldn't advocate for herself in the ER. She called me. I was like, and you're staying in the ER. And if I, it's like, so we lose these skills. So it is more likely, based on what we know about this our shared audience, they will listen, they will try, they will vet. It is more likely that we have a movement of patients who said, I'm no longer the good patient. I am going to do it, ask politely. I'm not saying to be rude or to throw tables. It is more likely for that to happen than for the medical curriculum to change and for doctors, the next generation of
I
doctors
don't
to
think the
come out and say,
curriculum's
"I
ever
don't
going to
know."
change, honestly. Like
Unlikely.
it's so unlikely that it will, at least in the current system that we have. There's no question about it.
A little bit of hope because, we've got people in there right now who are saying, "Listen, if you want federal funding, start teaching nutrition." That's a good start. You know, we're not we're not gonna blanketly
That's not gonna
ban
change the mentality.
I think there's I
But
think
who's going to fund it, right? Like who's going to fund that nutrition training? That's still considered nutrition training if it's coming from a system.
Yeah.
And we're going to get into a whole system conversation. We don't need to get
right.
into that right now. But somebody has to fund it, sadly. And the egg industry isn't exactly up to funding the thousands of med schools in the US. So 100%, the advocacy and the onus falls on the individual, the patient, to be able to rely on the skills that they have. I completely agree with you there. Listen to what your body is telling you. You're the only person that needs to live in your body. No question about it. When you get into that office, don't put the doctor on this massive pedestal and say you should know everything and what you say is gospel and that's how this is going to go. So go in, maybe not skeptical, but go in knowing that this is a utilitarian situation, just the same way that you would work with a social media representative or somebody that's doing something for you, that's working for you, an employee in some capacity, right? And when you reach the end of that capability, that utilitarian capability that that person has, then it's time to find somebody new or extend out your team into multiple practitioners because we all have different goals, right? So even like the best athletes in the
Yep.
world have coaches on top of their practitioners, on top of this, on top of that. And they have a swing coach for golfers and they have their caddy who's a different person. And they have numerous people around them that are working to help them be the best version of themselves. I think if we see ourselves as that pro athlete kind of mindset, we can start to advocate for ourselves better because we know our bodies better. We know how we can perform at the best capacity. So I agree with you. Hold yourself to a higher standard and have or use the people around you in a positive way to help you get further. Does that sound reasonably accurate there?
Yeah, that sounds yeah. But also it just
Oh, 100%.
and don't
I
be so
think
mad at them.
emotions are big. Yeah.
Yeah, I think it
I
doesn't
don't think
help.
I don't think being mad
Emotions,
at a
they don't
physician
help.
makes any sense in the world because as you're right, they did go into it for the right reason. Nobody spends 12 years in school to
Yeah.
be a jerk, as you said. I mean, that's not what people do.
Yeah,
So
no.
I'm not advocating that for a moment.
Yeah.
And I'm also not advocating, that you gotta be violent to break the system. But, I feel like I'm the radical on the call, or on the podcast here, but it's I look at it and I say, the system, in order to satisfy the 100% of the people that are out there, not just the 5% that may be listening to this podcast, but to that other 95% who aren't necessarily in a position to do any of the things that we're talking about, with the exception of standing up for yourself, because I think that's a really important thing, that everybody can do. But I think that inevitably leads to people, um, the system either needs to change or it's gonna get broken in a way that is far more damaging to everybody. That's just the way these things work. I mean, it's
Well, there's a
but
third choice.
it's a pathway that
Okay.
almost never happens. But go ahead. What is the third choice?
But there's a third choice, and it's a path that never happens, but, like, I have access to information more than ever, like, so we can't even compare it to past things. The system is not going to change. It's not going to change. I'm really happy that you're very excited about this one nutritional module it's not going to change. It can't change. Like, you haven't been in through the medical curriculum, like, enough, and you have not been I love you, but you
Oh,
have not been
trust
enough
me.
through billing and
I've been
coding.
through that.
The
I
system
know.
the
I
system
know the
ain't
feeling.
changing. Okay, so it's not changing. So we need to let go of the hope. As far as it breaking, it's already broken. It's broken. We would be much worse off if it was completely gone, because then we couldn't even get basic needs, prenatal care, and like we wouldn't have any basic needs, and so we would not want it to be broken to the point where it does not exist. So we don't want that. So the third option is how to use what we have. How to use what you got.
Figure out a coping mechanism because the system is really broken at the level of the provider and the payer, and that's really broken. So we as the consumer need to just find a way to survive in this system. And
Of course. I mean, but that's true of everything. The real estate market's really, really broken right now. People have to find a way where to live. You're not gonna change it. Like, that's true of everything. The little person and if I'm out here navigating, like, my thyroid vagus nerve journey, I really don't have time to be an activist and fixing and reforming healthcare system. So, like, am I gonna like, what am I supposed to do? The faster I get I like let go of like this rhetoric, like it's broken and it got changed and then they get political and am I blue? Am I red? And like it's so much more. I'm just trying to figure out my health journey. Just figure out your health journey and like use the system as much as you can. Um, this whole system level thinking it's hard enough to be a patient. Do I
I
have to
think the
really worry about
conversation is
fix
coming up
it?
where people are entering this conversation at two completely different areas, right? Dr. E, you're bringing in the concept or the timing where a patient's starting to feel sick or there's an issue going on with their health. They're compromised in terms of their capability, and there's a challenge that they need to resolve acutely or chronically based on their health not being optimized. JP is coming at it from a system standpoint in a situation where he doesn't have a health issue to contend with, and he's expecting more of the system itself. And I think there's a fair conversation to be had, but it depends on what situation you're entering into, right? Sure, a small nutrition module in every medical school is not going to change the system, but it is going to guide the concept that nutrition does play a role, just like you found out in your wife's story, that nutrition plays a huge role in creating autoimmune conditions, right? So we see that the system can be changed with enough outside influence being pushed at the right time by the right people in the right scenarios and the right situations. For an individual, and I know that the vast majority of people that are going to be listening to this are that individual that is navigating a health struggle. In that situation, don't worry about what the system is doing. Don't be upset at the system. Don't be upset at the doctor. Do what you can. Use it the way that it is in its current capability. But when people are healthy, when they're not in need of acute care in that like acute scenario, that's when I think we should expect higher, and we should have hope that the system can get better so that we don't have to continue to contend with the rising rates of chronic disease, right? That's where the change can be put in because we're not in an acute scenario. We're in a scenario where our life expectancy is decreasing for the first time ever, right? The rates of chronic diseases are through the roof, that people are on 3, 4, 5
But that's
medications.
not because of the healthcare. That's not because of the healthcare system. It's the
But they're
food
all linked
system. It's
together,
what we
though.
prioritize. That everybody watches the Knicks games from their
But
couch
they're
while they're eating
all
Doritos
linked
and beer. Like,
together. They're all linked together, right? The healthcare industry and the food industry are advertising during the Knicks game.
I know
So
it's always been baffling to me.
I see where you're coming from. We're not going to change the situation in this conversation. We know that for a fact. And weirdly, something is printing right beside me. That's so weird. I apologize for that. We're not going to change it. But I think
That's from
giving
God.
up the hope of change is actually a potential negative. And it's something that I can't get on board with, is saying that we have to give up hope on that scenario or on that potential. I think having hope for a better system is the only way that as a species, as a society, we can expect better from our voted in individuals, from our politicians, from our system.
Politics and activism. I hope for a better social justice also. And so I agree with you. If we're going to have a philosophical conversation, of course, we should change and start paying for preventative timing. That spending time at patients what not to eat is much better than paying me for more diseases that they have. Of course, the system should be changed. But w- at the end of the day, I think the people mostly listening to this, because it's a health podcast, not a political podcast, it's really about some people who are struggling. And the angst that we feel about it not changing. And I see most of the patients who end up, Dr. Habib, in your office, and when I used to see people, I mean, they're really angry and they feel like they've been burned or not listened to or gaslit. And that feeling is not helpful to them. So if they have a better understanding, my goal really is for those patients. If they have, I am not in any way, shape, or form saying this system is good. It's crazy. But for those patients who are struggling, the faster we get over that and just start using these people as plumbers, the faster we get to our health goals. But I do agree with you that the system needs to change. It's not going to change in time for Susie
Right.
to get her thyroid
No,
fixed.
I think there's a time scale here. Also, it's the two different levels, but also the two different. You're talking about a person who's going in for dealing with a problem they have right now, and how do you use that? Should you just follow blindly the advice and as if it's the Pope giving you, divine scripture to read? No. You have to recognize and you have to open your eyes and you have to be an advocate for yourself. And that's where you and I are 1,000% aligned. I mean, 100%. Um, I think it would be helpful for the clinicians who do have it in their hearts to be, to be good people. They want to do good, for them to be humble and to recognize the limits of their own knowledge and to be open the way Dr. Habib is. I think that would be helpful. I think that's probably a little bit of a harder throw. But I don't think it's
Yeah.
impossible. And I think that the newer generation of physicians are a little bit more open to recognizing the pace that things change. They're not looking and saying, well, my mentor's mentor did this, and so I'm going to do it, and I'm going to do it till the day I die. I think I'm hopeful that the statistic that I read somewhere, that most practitioners don't change what they do after 4 years out of training. That once they get 4 years out of training, nothing changes for them. Well, that's pretty scary considering the speed with which things are changing in the medical field. I hope that changes too.
It won't. Humans are humans, man.
Maybe. I listen, there's no question humans are humans, but I think that they're going to be pushed to do it. And I think they're open to it because AI is coming and it's here already in some cases. And I think that the legal field is actually going to push this too. I think that's the biggest fear that I have for the medical field, is the legal field, because there's going to come a point where the legal field's going to step in and say, you guys don't know everything. You guys aren't living up to it. And if you want to hold yourself out to be, these standards that you're holding people to, we're just not going to accept them as defense anymore. And then all hell's going to break loose, because you're going to.
I mean, that would certainly be helpful, because right now the legal field is actually what's keeping the indoctrination going, because as you practice, if you don't follow the standards, then any lawyer can come and say, "Oh, you didn't follow the standards." Not only the standards that are written, but the standards of in your region of whether or not, So if anything, the legal the idea of my practice lawsuit and the fact that providers have very minimal protection in this country against that, it's actually strengthening the indoctrination. It's like,
Yeah,
I'm
but
not going to
I
go
could see how
anywhere
that's going to
left or
break.
right,
It's going to
because
break. Well,
if that
what's
breaks,
going
that
to
would
happen
actually be
is
helpful.
the
I agree with you.
indoctrination that's coming out of the American Medical Association and the American Cardiology, College or whatever. The things that they're pushing are now being demonstrably shown through science to be wrong, and yet they still push it. And so what's going to end up happening is you're going to have lawyers go into the courtroom and say, doctor, yes, you followed the guidelines, but there was every indication that the guidelines were wrong.
I mean, it will be helpful to reduce the fear in one sense of malpractice, but also could create the Wild West, and that any quack can also say, but look at all this evidence that I have. And if he finds the right lawyer, it could point to this evidence. Like, if we're going to allow that to happen, that the slippery slope is that it really gets where anybody could do anything. If you could point to anything. Yeah. So I don't know that that's the utopia we're looking
every
for.
revolution gets bloody at some point, and I think it already is starting to, and I think it's going to get worse. So I'm encouraging those communities, the physicians and the medical societies, to get their act together, because that revolution is coming, and don't stand in the way of it. Fix yourself now.
I think this is a great way to kind of pull it together, because we definitely came from two different perspectives on this. We had a wonderful debate here. We tried to understand the perspective that each of us was coming from. Oh, it's
going to be a top-performing podcast.
I love it. I love it.
I'll have you on every week.
Debates are the best, and I think what we're able to do when we debate this is actually create some spark for potential change, whether at the individual level, where individuals can advocate for themselves, actually show up to their doctor's office ready to talk, ideally not in a hyper emotional, hypercharged way, and expect that their doctors are going to be the best and ideal in knowing everything at the top of their game all the time, but rather in a utilitarian fashion. And that the system can start to see that maybe we're treating chronic illness not the exact right way. Maybe from a system standpoint, policies can start to be changed, because ideally somebody who's listening to this conversation is going to get elected into government and have the ability to create a policy that actually does change something, right? Yes, the chances are low, but I think giving up hope is also a slippery slope on the other side. So what I think we want to kind of end on today and bring it down to is, as an individual, you need to stand up for yourself. You need to be aware of what's going on in your body. Nobody else is living your life. Nobody else lives in your body. Listen to what your body is telling you. Understand pattern recognition. Understand what's going on around you. Do your best to create an environment that's as healthy as possible for you. And where there is a need, seek out that help, but use it in a utilitarian fashion, not in an emotionally charged negative fashion. On the system side, that's a whole nother story. We'll get there one day, hopefully. Dr. E, thank you for joining us today. I would love to share your book, your socials. Where can people learn more about you and follow you further?
Thanks. Medicaldisruptor.com. It is there for you. We really don't sell anything. My wife used to ask me, why do you do this? I'm like, I don't know. I'm spreading the gospel, different gospel. And so that people could find people like Dr. Habib and other practitioners who are keeping, to your point, JP, who are keeping their curiosity forever. So medicaldisruptor.com, and on socials, it's efratlemandre.com. So yeah, just come, hang out. Dr. Habib, thank you so much. I think your interjection about the two different perspectives and how we're coming to the same topic was very, very helpful. So thank you for that perspective.
I seek to be the middle ground in many conversations. So this is where I tend to end up.
You are King Solomon.
This was great. JP, any final thoughts on your side?
No, I really enjoy a lively debate, and this was, you're right, this one was top of the list of all the podcasts we've done in terms of debate. And I 1,000% agree with you on the patient level. I think on the provider level, we both agree it would be good. I just think you're sort of wanting to abandon hope that that's going to change because people don't change. I kind of have hope still that maybe call me that doe-eyed, that freshman in med school thinking that's going to change, but yeah, so.
I love that.
I love it. Great conversation, everyone.
Amazing.
Thank you for joining us, Dr. E. And JP.
Thanks.
And for anybody who got to this point and you thoroughly enjoyed this wonderful debate that we had, please share this with somebody who's going to get elected to office and can create the change in the world that we are seeking. And we honestly had a great time here today. Thank you again for listening. We'll catch you all on the next one.